Hi friends, today I will discuss or talk about SGLT2 inhibitor. This video is made for educational purpose only and there is no endorsement for any brand or company. Uh, Initially we thought that diabetes causes immense damage to the kidneys and kidneys were the victims, but nowadays it has been proved that kidneys, they are not only the victims but they also cause or they have an important role in pathophysiology of diabetes mellitus. As we have read in physiology, all ions are reabsorbed in the proximal convoluted tubule. This is the proximal convoluted tubule. Most of the filtered ions from the glomerulus, they are reabsorbed back into the blood, except the potassium, which is reabsorbed in the distal convoluted tubule. This reabsorption of the ions occurs in the proximal convoluted tubule through the sodium glucose transport channels. These SGLT2 channels, they are present on the proximal convoluted tubule in the apical membrane, or we can say apical cells. Most of the glucose or filtered glucose, approximately 90% of the filtered glucose is reabsorbed in the proximal convoluted tubule through these channels along with sodium, and this sodium in turns then goes back to the blood through the GLUT channels. So the action of these SGLT2 inhibitors is on these SGLT2 channels in the proximal convoluted tubule. They cause inhibition of these channels, so the reabsorption of the glucose and sodium is prohibited, and both these glucose and sodium, they get excreted in the urine. When this glucose is excreted in the urine, we call it as a glucosuria, and when this sodium is excreted, we call it a natriuresis. In normal individual, the renal threshold for glucose is 180 mg per deciliter. It means when the blood glucose level rises above 180 mg, then only the glucose gets filtered get excreted in the urine. But in diabetic patient, there is overexpression of the SGLT2 receptors. Overexpression means there is increase in number of SGLT2 receptor in the proximal convoluted tubule, so more and more glucose gets reabsorbed and the renal threshold for glucose rises from 180 to 240 mg. The SGLT2 inhibitors, they block these SGLT2 receptors, so the filtered glucose doesn't get reabsorbed in the proximal convoluted tubule, and it gets excreted along with sodium through the urine. So they cause lowering of the renal threshold in diabetic patients. These SGLT2 inhibitors, they enable around 20 to 30% of the filtered glucose, that is 50 to 100 gram per day, to be eliminated in the urine of the patients with diabetes. With the use of these SGLT2 inhibitors, as the blood glucose level falls, the amount of the filtered glucose also declines, and the blood glucose level comes to the euglycemic range, that is normal range. And as the blood glucose level comes in the normal range, the effects of these drugs also declines, so there are very little chances of frank hypoglycemia in patients who are on SGLT2 receptors inhibitors. As we know that this mechanism is insulin independent, they continue to operate under the conditions of the patients with increased insulin resistance and beta cell failure. The glucosuria, which is induced by these drugs, help in weight loss, and they have a very mild osmotic diuretic effect also, which contributes to a very small reduction in blood pressure also. The weight loss caused by these SGLT2 inhibitor is about 2 to 4 kg, and they lower the blood glucose by 40 to 60 milligram with the HbA1c reduction of 0.6 to 1.2%. We know that the early diabetic changes in kidneys are hyperfiltration. This hyperfiltration is because of SGLT2 overexpression. Means in diabetic patient in the early stages there is overexpression of the SGLT2 receptors in the proximal convoluted tubule. So when there are increase in number of SGLT2 receptor in the proximal convoluted tubule, there is more and more glucose and sodium reabsorption in the proximal convoluted tubule. So very less sodium goes to the macula densa, and when very less sodium goes to macula densa, it causes afferent arterial vasodilatation and decrease in efferent arteriolar vasodilatation, or we can say increase efferent arteriolar vasoconstriction, which leads to increase in GFR. And when there is increase in GFR, there is more and more protein loss from the glomerulus, that leads to albuminuria or proteinuria, and the patients have nephropathy. But when SGLT2 inhibitors are given to these patients, there is the reabsorption of the glucose and the sodium gets reduced. So more and more glucose, or we can say more sodium, goes to the distal convoluted tubule, and in the distal convoluted tubule there is a macula densa. When the macula densa senses that there is increased delivery of a sodium to this macula densa, it causes afferent arteriolar constriction and efferent arteriolar vasodilatation. So there is normalization of the GFR, or we can say there is decrease in the GFR in the diabetic patient who had initially high GFR. So this prevents the protein loss or albumin loss, and hence they have a protective effect on the nephropathy. Important SGLT2 inhibitors are Dapagliflozin, Empagliflozin, Canagliflozin. These three are very commonly used nowadays. We have Atugliflozin, Empagliflozin, Tofagliflozin, Remogliflozin, Bexagliflozin, and we also have Sotagliflozin. It has dual action on SGLT1 receptor and SGLT2 receptors. The SGLT1 receptors, they are present in the intestine and distal convoluted tubules, so they have an additive effect. The SGLT1 receptor, when gets inhibited in the intestine, they decrease the absorption of glucose in the intestine, so they have a very dual effect of hypoglycemic control. I will discuss about Sotagliflozin in my another video. So let us compare the effects of three important SGLT2 inhibitors like Dapa, Cana and Empagliflozin. All three are indicated in type 2 diabetes only. The dose of Dapagliflozin is, we have to initiate with 5 mg. We can up titrate to 10 mg, and it has to be taken before or after breakfast. Canagliflozin dose is 100 mg to start with. We can up titrate to 300 mg, and it has to be taken before first meal of the day. Empagliflozin, we have to start with 10 mg. We can up titrate to 25 mg. Can be taken before or after breakfast. All these three SGLT2 inhibitors, they require no dose adjustment in renal impairment if eGFR is more than 60. Dapagliflozin we should not start if eGFR is less than 60, and it is contraindicated if eGFR is less than 30. Similarly, for Canagliflozin we should not initiate if eGFR is less than 45, and it is contraindicated if eGFR is less than 30. No dose readjustment is required if the eGFR is less than 45 for Empagliflozin, and it is also contraindicated if eGFR is less than 30. So all these three drugs are contraindicated in severe kidney disease if eGFR is less than 30. All these three drugs can be used in mild to moderate hepatic impairment, but they are all contraindicated if there is severe hepatic impairment. We can use these gliflozins in elderly patients, but the risk of fracture or fall is more with the Canagliflozin. They have a category C indication in pregnancy, lactation they are contraindicated, and in type 2 diabetes mellitus they are not to be used. So they have very protective effects on almost important organs of the body. In heart, they decrease the cardiac preload, they decrease the ventricular remodeling, atrial remodeling, they improve the systolic dysfunction, they improve the diastolic abnormalities, they improve the fibrosis, especially post-MI cases. They also have uricosuric effects. They decrease the body weight or body mass, they cause ketone loss in the urine, they promote lipolysis, and they have a reduction in the insulin resistance effect. They improve the endothelial function, they decrease the vascular stiffness, they have a blood pressure lowering effect, they reduce the volume overload, they increase the hematocrit and have a improve the oxygen supply to the vital tissues. As they also cause sodium loss along with the urine along with the glucose in the urine, they cause natriuresis, they have a positive tubuloglomerular feedback, they reduce the nephropathy by reducing the albumin loss in the urine, they decrease the fluid retention or edema. Various FDA approved indications for SGLT2 inhibitors they are used as adjunct in type 2 diabetes patients. They can be used as adjunct to diet and exercise, and we should not give them in thin diabetic patients. They can be used in patients who have an established cardiovascular risk or disease, for example patients with prior myocardial infarction or heart failure patient or non-fatal stroke. We should avoid in these these drugs in CKD patient, especially if they have a very low GFR, that is less than 30. They can be used in heart failure with preserved ejection fraction. Dapagliflozin is FDA approved for the treatment of heart failure across full spectrum of left ventricular ejection fraction, including heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, heart failure with median ejection fraction. EMPA is more potent than DAPA in HbA1c and weight reduction, but it is relatively more expensive than DAPA. The contraindications of SGLT2 inhibitors are type 1 diabetes, diabetic ketoacidosis, pregnancy and lactation. They should be avoided in children less than 18 years of age, and severe kidney disease if the eGFR is less than 30. The SGLT2 inhibitors they cause euglycemic diabetic ketoacidosis. As we know, they cause glucosuria or decrease sodium resorption, so they cause euglycemia, means control the blood sugar to the normal range, but they also cause decrease in insulin secretion or increase in glucagon because of increased counter-regulatory hormone like catecholamines, corticosterone, glucagon, and because of insulinopenia or decreased insulin, there is increased lipolysis, increased free fatty acid delivery to the liver, and hence they leads to ketosis. So because of this euglycemia and ketosis, we call it as a euglycemic diabetic ketoacidosis. Various adverse effects seen with the SGLT2 inhibitor use are genital mycotic infections because of their glucosuric effects, and or we can say because of glucose loss in the urine, the glucose in the urinary tract or genital areas promotes the bacterial or the fungal growth, and it leads to genital mycotic infection. They cause UTI or pyelonephritis, lower limb amputation, especially in patients with history of diabetic foot or neuropathy, especially the patients who are on canagliflozin. We have seen a few cases of patients who had diabetic foot or neuropathy. They end up with a lower limb amputation, especially when they were on canagliflozin. They also cause euglycemic diabetic ketoacidosis. Acute kidney injury is seen in patients, especially because of dehydration, and if we can give them in volume overload stage, but we have to avoid dehydration because it will lead to acute kidney injury. Hypersensitivity reactions are seen in few patients. Bone fractures because of fall is especially seen in elderly patients and the patient with who are on canagliflozin. Hypoglycemia is rare but can be seen if they are combined with insulin or other insulin secretagogues or other anti-diabetic drugs. About the bladder cancer, it is not proved yet, but few physicians think that it can cause bladder cancer also. Hyponatremia is seen because of excessive diuresis, and both hypo and hypernatremia can be seen depending upon the amount and the duration of its use. They should be stopped 3 days prior to the surgery. Thank you. It was all about the SGLT2 inhibitor. In my next video, I will talk about oral incretin therapy. Thank you very much.